Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back, everyone. Today we are going to look at a paper comparing biologic mesh versus synthetic mesh for contaminated ventral hernias, which was recently published in JAMAsurg. It's a slightly shorter episode than usual. We couldn't bring you a presentation this time concerning a teaching topic, but we'll make it up for you for next time. Stay tuned.
So the paper that we're presenting today is called Biologic versus Synthetic Mesh for a Single-Stage Repair of Contaminated Ventral Hernia Repairs. It's a randomized clinical trial, and we've taken the article from JAMAsurg, which was published on the 19th of January. Below is the link for the abstract, and the PubMed ID is also there. My name is Özlem, and my colleague is Gio, as you all know.
Excellent. So let's start with a little bit of background about this paper. So we know that ventral hernia repair is a very common general surgical procedure. Actually, in the States, the estimated cost related to this procedure is 3.2 billion per annum, which is quite a lot of money. And we do know that biological meshes in the context of ventral hernias have been considered traditionally suitable for contaminated hernias, particularly clean contaminated and contaminated procedures. They are traditionally considered safer in that context. However, data from the literature shows how morbidity associated with the mesh and recurrence rate seems to be actually higher in using a biologic mesh. And according to the authors, no rigorous study looking at the safety and efficacy of biological meshes to date has been conducted concerning this particular topic. So the authors hope to shed some light on this. And they particularly focus on clean contaminated and contaminated procedures, as you can see on the table on the right.
The authors hypothesized that the synthetic mesh would result in superior hernia recurrence risk with similar safety and lower cost compared to with the biologic mesh. So essentially what they were saying was they feared that the permanent synthetic mesh would lead to chronic infections and further complications or reoperation. Let's have a look at the population involved in this study. So the authors included adults undergoing single-stage repair of clean contaminated or contaminated ventral hernias. In this case, they consider adults 21 years old or older. They also deemed necessary a hernia defect of 9 square centimeters or above. They only included, as mentioned earlier on, class 2 or 3 CVC contaminated wounds. Only elective single-stage repairs. In order for the patient to be eligible, intraoperative fascial closure had to be achieved. So no bridging was allowed, basically. And obviously the patients need to be accepting both meshes before being put to sleep and having a general anesthetic because they are randomized intraoperatively. A variety of exclusion criteria are used by the authors, including malnutrition, low albumin, etc., etc. Just put in there a couple that are particularly relevant. They excluded patients with a BMI over 45, and patients that were smoking within 1 month of surgery. So our PICO question for intervention and comparison specifically was patients were randomized to retromuscular synthetic or biologic mesh at the time of fascial closure. The biological mesh was non-cross-linked porcine dermis, which was the current standard, and the intervention was a synthetic mesh, which they used a medium weight polypropylene as the intervention. Back to you, Gio. Right, and let's have a look at the outcome. So the outcome that they considered as a primary outcome, as a measure of efficacy, is hernia recurrence at 2 years. This is measured with a mixture of clinical criteria, radiological criteria, and self-reported criteria. Clinical criteria are obviously examination by a member of the team. Radiological is via CT or via ultrasound. There doesn't seem to be, even going through the appendices, a specific protocol to guide radiological decision-making, whether a patient goes for ultrasound or CT and at what point in time. And self-reported using a hernia recurrence inventory is a further method that they use.
Hernia recurrence inventory was apparently introduced a few years ago in the States, and the original validation study determined that if patients experience a bulge at the area of the previous hernia, and they report that, apparently this is quite accurate in actually identifying hernia recurrence. Patients that are positive on recurrence inventory gets offered a radiological further assessment. Secondary outcomes that the author looked at are mesh safety, 30-day hospital direct cost, prosthetic cost, and quality of life. Concerning the primary outcome, this is a superiority trial and is designed based on a pre-assumed difference between the two treatments in terms of recurrence rate of 9 versus 29% for synthetic versus biologic. So with the synthetic mesh being superior. Ball to you, Aslam.
Thank you. So let's talk a little bit about the study design in the method section. So the type and the subtype of the design was, it's a randomized controlled trial and it's single blinding, which I'll talk a little bit about further below. The setting were 5 academic medical centers in the US specializing in abdominal wall reconstruction. These were tertiary centers. All the clinicians were highly skilled, the most junior being a clinical fellow and above. The period of enrollment, the trial or the surgery started between December 2012 until April 2019. They were followed up at specific points such as day 1, 30, 6 months, 12 months, and 2 years. So the last patient was seen in April 2021. Some methods were adopted to reduce the bias. So patients were enrolled by physicians and research personnel from clinics from these centers. Randomization sequence was generated using by a statistician. Central concealed randomization scheme was housed in REDCap. REDCap stands for Research Electronic Data Capture, and they use random number blocks. They tried to use minimization or stratification, allocation executed by the research coordinators themselves, and then the patients were randomized in theatres 1-to-1 between synthetic and biological meshes immediately before mesh deployment. As I said, it was a single-blinded, so the investigators knew up until mesh placement, whereas the patients were blinded right up until the end of the conclusion of the study itself. Back to you, Gio.
Right, let's start having a look at the results. So in total, they had 253 patients enrolled, which is about what they expected to enroll based on their patient sample size calculations. 126 were randomized to synthetic mesh and 127 to biologic mesh. And age and gender distribution are as advertised. As you can see, they have a wonderful adherence to protocol. Every patient that's allocated to biologic mesh gets a biologic mesh. Every patient that's allocated to synthetic mesh gets a synthetic mesh. And as you can see, their follow-up is actually reasonably good, particularly at 2 years. They designed some interventions approaching the 2-year follow-up point, whereby they were sending patients some reminders, which they didn't at 6 months at 1 year, hence the increased follow-up at 2 years. As you can see, patient characteristics were pretty similar between the two groups, particularly considering conditions such as Crohn's or ulcerative colitis, which would obviously make you catabolic and more likely to develop a wound complication, as well as a history of smoking. They don't go into much more details about how much smoking per se. And on the right side on the table, you can see a few intraoperative characteristics, such as intraoperative time, which, as you can see, is pretty similar, as well as access, which was pretty much in 100% of the cases midline laparotomy, as you expect in a ventral hernia. There's quite a few stomas in this cohort, obviously accounting for the source of contamination as well. And of note, they talk about enterotomies as a source of contamination, which obviously is probably accidental, and they do mean that the enterotomy stepped up the degree of contamination of the wound, and the patients were included beforehand as a simple repair.
We're talking about primary outcomes on this slide. So efficacy was the primary outcome, and efficacy in their discussion is essentially efficacy was measured by the 2-year hernia recurrence rate. So the hernia recurrence rate at 2 years was 13% overall for everyone. But when it was broken down to which type of mesh the patients had, you can see that there was a greater hernia recurrence rate with the patients who had the biologic mesh at 20.5%, whereas a synthetic group had only a 5.6% recurrence rate at 2 years point. So the synthetic mesh was significantly reduced the risk of hernia recurrence. As you can see, the hazard ratio, the 95% confidence interval, as well as the p-value of less than 0.001 showed that there was a significant difference between the two groups. Back to you, Gio.
Excellent. A quick Kaplan-Meier curve to graphically highlight what we just discussed. So as you can see, at 24 months, there's quite a visible difference between the biologic group and the synthetic group. Obviously, they do have for some patients longer follow-up, but as you can see, the population at risk after the 24 months, which is the formal end of the RCT, goes significantly down. Ball, back to you.
Thank you. So the secondary outcomes, one of the main secondary outcomes that they looked at was safety. The way that they defined safety was that safety was measured by surgical site operations requiring procedural interventions, such as wound debridement, percutaneous drainage, etc. So when they looked at the safety, they found that there was no significant difference overall in surgical site occurrence requiring a procedural intervention between the two groups, whether it was the synthetic or the biologic mesh. They also looked at cost, and when they looked at the 30-day costs, direct hospital costs, they found that the biologic group was much higher at nearly $45,000, whereas the synthetic mesh group were only $17,000. Again, there was a statistical significance there of a p-value of less than 0.001. With regard to specific direct cost of the meshes itself, the biologic mesh itself cost over $21,000, whereas the synthetic mesh only cost just over $100. Again, there's a significance there. And one of the other secondary outcomes that they looked at was quality of life. Now, they measured using standardized scales. They measured quality of life at the beginning, so at the baseline and at various points. But they found that there was no difference, a significant difference between the groups at all at any time point, and they found that overall all of the patients' quality of life improved by the end of the study, essentially. Back to you, Gio.
Wonderful. So very briefly, they looked at adverse events, which is basically a composite measure of pretty much anything adverse that happens to the patient after their operation. And as you can see, a lot of patients had some degree of adverse event, up to 60%. These were more common in the biologic mesh group, again 66 versus 51%, and they also tended to be more severe as in terms of overall scoring. So
looking at the paper itself, these are some of the things that the authors reported themselves. So they said that they only used two materials specifically, as we said, polyproline and porcine dermis. They only looked at ventral hernias. The baseline characteristics were similar for all patients, but they hadn't power to control every single factor, essentially. They also suggested that the outcomes may not be reproducible in other centres. As mentioned, these were 5 tertiary centres with highly skilled surgeons, and it may be difficult to apply these or get these results elsewhere, and they readily declared that. Follow-up at 2 years was good and similar for both groups, but rates were quite variable at the interims prior to 2 years. Also, the patients and assessors were blinded to treatment allocation, but there were points when some patients had to be evaluated clinically by physicians, and unfortunately it had to be done without blinding owing to some constraints. And finally, at the start of the trial, they could only get one specific size of biologic mesh. They don't then say at what point they were able to get various different sizes of biologic mesh, but they do declare that at the beginning they only had a 20 by 30 centimeter biologic mesh available to them for the study.
Few points that we picked up reading the paper and reading the supplementary material. So there's no follow-up beyond 2 years, at least for the vast majority of the patients enrolled. This is, part of the design of the trial itself. It's a limitation in the sense that people can very much develop recurrences of the hernias beyond 2 years. But there's not much you can do about that. Something that the authors could have done something about, perhaps, and I found really difficult to wrap my head around despite reading the supplementary material, is the way the radiological follow-up was organized. a group of patients at a CT, a group of patients at an ultrasound, it's impossible to know based on the data they provide how many recurrences were actually pure radiological recurrences and not clinical recurrences, and what drove the choice between doing a CT versus an ultrasound. On top of that, patient-reported outcomes play a big role here. As we mentioned, there's a hernia recurrence inventory involved in the design of the study, whereby patients can self-report the presence of a recurrence. All these patients get offered a radiological investigation, which they can accept or decline. If they accept it and the radiological investigation says that they don't have a recurrence, obviously they don't have it. If the radiological investigation does not get carried out, they get assumed as having a recurrence anyway. And it's not clear to me how patients are encouraged to report their recurrences. A further limitation is related to the fact that they didn't include diabetes in the hazard model that they created to support to correct for a variety of variables when comparing synthetic versus biologic. Diabetes is a known risk factor, at least poorly controlled diabetes, for recurrence. History of smoking is very poorly described and specified. Being off smoking for a month doesn't make you an ex-smoker. And patients might very well have been smoking after the operation has been done. And it's unclear whether this is recorded or not. There's a parostomal hernia involved here. Obviously, the main reason for operating on this patient must have been a ventral hernia component. And patients that had a recurrence, but there was only parostomal, were actually not accounted as having a recurrence because the recurrence was not related to the ventral hernia itself. Honestly, saying that the radiological assessors are blinded, which the authors say that they are, it's probably not entirely true for two reasons. Where radiological assessors are surgeons involved in a trial to a certain extent, but pretty much everyone should be able to see, if they're trained to interpret a CT scan as these surgeons are, whether there is a residual mesh or not, especially at 2 years. And the biological mesh would not be expected to be there anymore, while a synthetic mesh would be. Furthermore, they probably have access to reports, which would highlight if there's, potentially could highlight if there's a mesh or not. And finally, a quick point about fascial closure. Now, achieving fascial closure is considered an inclusion criteria here. You don't really know if you're going to achieve fascial closure until you're actually doing the operation. Obviously, the authors achieved that in 100% of the cases. And I must assume that they did not have any case where fascial closure was not possible and patients were therefore excluded, because that would have been evident in the consort diagram, but it's not clear from the text. And generally speaking, I found that a lot of these things, including inclusion criteria, are not reported in the main text of the paper. You have to go through the supplementary material just to know the inclusion criteria and details. So ball back to you, Özlem, for conclusions.
If we move on to the next screen, please. So in summary, the synthetic mesh showed a superior two-year hernia recurrence risk in comparison to the biologic mesh, which initially that's not what they hypothesized at all. And they had similar safety profiles and quality of life profiles, but the synthetic mesh was significantly cheaper than the biologic mesh. We've put a perspective table below for you to look at. We're not going to read each point, but we've tried to summarize the good and the bad points of the methodology and the clinical or domain expert areas. That's the end of our presentation.
As usual, a brief summary of the discussion we had concerning the paper. Now, the first point we made relates to the concept of efficacy and effectiveness. The authors highlight how they want to look at the efficacy of biologic meshes compared to synthetic mesh. Now, efficacy generally refers to the performance of an intervention in ideal conditions. Whereas effectiveness relates to the efficacy of an intervention in real-world situations. The authors do use patient-reported outcomes as part of their primary outcome measures. It does suggest that perhaps they were looking at effectiveness more than efficacy. However, it's worth noting that every study that we talk about stands in a spectrum between those two concepts. A further point that we made relates to the choice of designing this as a superiority trial in relationship to a lower occurrence rate in favor of synthetic mesh. Now, the authors highlight in a variety of points how there are also concerns associated with the safety of biologic mesh, in terms particularly of adverse events and local complications. We therefore questioned whether this should have been designed as a non-inferiority trial, the primary outcome related to the safety of the mesh, and looking at a non-inferiority of a synthetic mesh versus biological mesh. Also because the authors quote a significantly lower occurrence rate for hernias in synthetic mesh use as part of their sample size calculations. Which brings us to a further point, which is quite relevant. If the literature published before this trial suggests that there is a difference in recurrence rate of 29% versus 9% of biologic versus synthetic mesh, presenting such data to patients to enroll them in a study would raise the question whether why would they expose themselves to such a higher recurrence rate by the possibility of receiving a biological mesh rather than a synthetic mesh. And finally, we looked at the relevance of patient-reported outcomes in general. So, as you can probably guess from the presentation you just listened to, we felt that using patient-reported outcomes in the context of a primary outcome, such as this, could potentially result in some false positive or false negative report of recurrence. However, it is important to highlight how patients' involvement is becoming more and more relevant in the design of a randomized clinical trial, also for accessing resources such as financial support from charities and patients' associations. And ultimately, there's always an argument about the relevance of a clinician opinion versus a patient opinion. Ultimately, the patient is the one having the recurrence. Hence the importance of the patient-reported outcomes in this context. Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.